My name is Erica Bostic, and I'm an adolescent medicine physician at the University of Rochester, and I'm also a faculty member as part of CEI's Sexual Health Center of Excellence. And I'm really excited to be here today to speak with you about case studies in initiating discussions of sexual health. I have no financial disclosures, but I do want to take just a moment to acknowledge and disclose my privilege. So I am privileged to be here speaking with you. I am privileged to be healthy and have a job, and it just feels important to recognize that right now. By the end of this talk, I hope that you'll have a better understanding of the importance of obtaining a sexual history, list the components of a thorough sexual history, and apply those skills to different patient populations that you may engage with. So why even talk about any of this? Well, if you think about it, sexual health is health. It's about risk assessment, and this can be in many different ways. STI risk, HIV risk, the risk of an unintended pregnancy. The information that you gather during this part of the history and physical may clue you into risk factors of intimate partner violence or sex trafficking. It also allows you to identify, foster, and cultivate protective factors for that patient. Preventative strategies, so not only STI prevention, but contraception, expedited partner therapy, PrEP and PEP, all these things. It also builds on trust and rapport building, and so really allowing the patient to feel comfortable sharing really deeply personal stuff without judgment. And like so many things in medicine, the sexual health can really be a team-based approach. And really from the first step into the door, into the waiting room, every team member can play a role in this. So some background information to really have a better understanding of why this is so important. So when we look at STIs, the overall trend is going up. However, certain patient populations seem to be more affected. So you can see in this top graphic, chlamydia going up, but really is affecting young women in the young adult and adolescent population. As of 2018, it was the 5th straight year of STIs surging. And you can see that's chlamydia, gonorrhea, syphilis, and sadly congenital syphilis as well. Adolescents make up a huge chunk of this population. And so 1 in 4 sexually active adolescent females has an STI. About 50% of all new STIs reported are in the adolescent and young adult age group. And in 2017, over 1 million cases of chlamydia were in the 15 to 24 age bracket. And that's over 62% of all cases. What about HIV? You can see several graphs here, but really what they're showing is that the majority of HIV infections are in the young adult population. Disproportionately affects Black and Brown people, those who identify as male, but actually the sex assigned at birth / gender identity is not really clarified in the CDC data from 2018, and reported MSM contact for those males. Again, adolescents are a major contributor here. And so really we see 1 in 5 of all new HIV diagnoses are in adolescents. Again, disproportionately affects Black and Brown youth, and the majority of cases are in those who identify as MSM. Talking about unintended pregnancies, particularly in teens. So overall, the data shows that it is downtrending, which is good. You can see here in this map from the CDC that the lighter yellow portions are lower rate of unintended pregnancies in teens, and the more red it becomes, the higher the rate. This is a very clear geographic distribution, and it's likely related to reproductive health laws affecting minors, which we'll talk about a little bit later, and also racial and ethnicity disparities. Why talk about pregnancy and contraception in the first place? Really, regardless of age, I guess postmenopausal would be excluded, but it really comes down to reproductive justice and reproductive autonomy. Our patients have the right to make informed decisions about their reproductive health. And that is not for us to decide, it is for them to decide. Our role is to provide them the information and the tools that they need to make that decision for themselves and really help prevent unintended pregnancies. But in terms of contraception, there are many methods to choose from. And that's okay, that's not a bad thing. There are many studies out there and evidence-based guidelines, which we'll touch upon as well, to help you. And yes, it can be uncomfortable to talk about sex, but I'm hoping by the end of this talk, you'll feel less uncomfortable. Setting the stage is really important, and you'll hear me say this many times, but making the patient feel welcomed, comfortable, and affirmed in the healthcare space from the moment they step in is critical. Normalizing the conversation, so asking all of your patients their sexual history. Aiming for a smooth transition into the social history, less abrupt, and we'll talk about that. Using open-ended questions when possible, and really avoiding making assumptions and judgments. We're all human. We need to acknowledge that this may and will happen, but really being mindful of it. And let the patient know why you're asking these questions. It's really regardless of age or gender, and really using developmentally and cognitively appropriate language. And so we'll frame our discussion with a case. And so Michael is a 45-year-old male who presents to the PCP's office for a new patient visit. You've gone through his chief complaint, medications and allergies, past medical and family history. Which of the statements below best sets the stage for diving into the sexual history gathering? A, okay, sir, I need to ask you about how many women you have had sexual contact with. B, do you have any drug allergies? I have some personal questions that I'm curious about. C, I'd like to shift gears and ask you some personal questions relating to your sexual history, as I do for all patients. Would that be okay? And D, I need to ask you some questions about some things that, never mind. All right. So the vast majority of you, 87%, chose C. I'd like to ask you some personal questions related to your sexual history. And so if we go through the answers on the slide, we can see that really choice A is making an assumption, right? You're assuming that because this person is a male, that they're having sex with women. Choice B really is not a smooth transition. And the worst thing you maybe could do is have a patient think that you're asking these personal questions because you're curious. I would avoid using the word curious altogether. C, so this really has a smooth transition. We're letting them know and acknowledging that we have personal questions to ask, normalizing it, we ask it of all patients, and checking in to make sure it's okay that we proceed. And choice D is avoidant. So do not avoid these questions, please. Here's some examples of language to set the stage, similar to what we just saw. So just so you know, I ask all these questions to my patients regardless of age, gender, or marital status. These questions are personal, but the information is important so I can support your overall health. Like the rest of our visits, this information is kept in strict confidence. Do you have any questions before we start? Like so many things in your training, if it's anything like mine, mnemonics have been your friend. The HEADS assessment for adolescents, I use this a lot and I use it in combination with the 5 Ps. And so this is really for social history gathering, which you can see there are many components of, and the sexual history is one of them. And the CDC uses the 5 Ps or talks about the 5 Ps. And that stands for partners. So the sex assigned at birth of a person's partner, the number of partners in the last year or 3 months, and that sort of gets gives you a sense of what role sex is playing in this person's life. Practices, so types of sex, it's really important for you to have an understanding of what types of sex a person is engaging in, and we'll talk more about that in a minute. Protection from STDs, so this is the language from this PDF, really, as you know, we refer to it as STIs, and that's part of the risk assessment and seeing if condom use is something that could use a little work. Past STI history, so we know that a history of STIs can increase the risk of future STIs. And the last P I would phrase as parenthood intention, so kind of takes gender out of it. And so that's a nice opportunity to explore any contraceptive needs and link to prenatal care if applicable. Again, I will say the CDC booklet here is a bit outdated in terms of language and approach. And so I'll refer to a different source later in our talk. Asking about sexual behaviors. So again, really important to normalize the conversation and really be specific. We need to know if a person is having sex or has ever had sex and what type of sex that they're having. And so you can ask, have you ever had oral sex, vaginal sex, anal sex, all of the above? And be prepared to potentially explain what each of those mean and are. Are you having safe sex or using protection? And we'll talk particularly with adolescents, avoiding some of these phrases and really asking what that means can be more helpful. You want to screen again for any risk behaviors, so survival sex, trading sex for drugs, money, or shelter. Screening for abuse, so has anyone ever touched you in a way that you were not okay with? Sexual wellness, so really trying to take a sex positive approach. Do you have any concerns about sex? And again, parenthood intention. In the next few years, do you see yourself becoming a parent? So more on Michael. He tells us that he meets his sexual partners online. He prefers assigned males. He has up to 10 new partners per month and uses condoms sometimes. After hearing Michael's responses to some of the 5 Ps, counseling may include A, wow, that sounds pretty risky. You should really only have one partner. B, you probably have a lot of STIs. We should treat you for everything now. C, I'm going to refer you to an infectious disease specialist. Or D, based on the information you shared, I have a few ideas about strategies that may decrease your risk of infection and keep you healthy. Great. So 94% of you chose D. Excellent. So we'll go through them one by one on the slide. So choice A, that's really judgmental, don't you think? You know, we don't want that. Choice B, making assumptions. We want to check those at the door. C, I thought this audience would particularly appreciate, right? So any clinician can and should ask these questions about sexual practices and counsel about preventative strategies. A little tangent talking about PrEP is that the USPSTF, so most of you may know that that's one of the sources of guidelines for primary care providers, rated this PrEP, like provision of PrEP, as a grade A recommendation. So meaning it is in the wheelhouse of primary care providers. Doesn't have to be an infectious disease doc or provider that prescribes PrEP. Taking a harm reduction approach is generally a good practice. And so that really entails access in general. And so having condoms readily available in your clinic for free. STI screening, site specific, because you've acquired that information about what type of sexual practices they're having and really normalizing that. EPT, so for chlamydia, and at least in New York for about a year now, gonorrhea, and hot off the press, I don't know about other states, but in New York, trichomoniasis now we can use EPT for if a person does not have syphilis. Comprehensive contraception counseling and provision. So if your clinic or workplace is not able to provide all contraception, be sure to know who to refer to. PrEP and PEP, so HIV prevention services, and really recognizing that this is deeply personal stuff, and it may take a few visits to really build that rapport and trust to get all this information. And this is really a great time to bring in your interprofessional team. So maybe that looks like case management to identify needs or help link with medication assistance programs, vocational assistance, mental health providers, so reeling in our colleagues there. Substance use, so there could be a comorbid substance use disorder that could use assistance, and other local resources. Sometimes this looks like also a pharmacist coming in or a PrEP specialist to really talk about the medication and adherence strategies. So key takeaways: STIs are common, preventable, and treatable. Take time to set the stage before diving into the sexual history. Mnemonics are your friend, and they can keep your social and sexual history organized and thorough. Be specific and normalize the sexual history and take a harm reduction approach. So let's take this information that we learned in section 1 and apply it to 2 different patient populations that a lot of people, in my experience with, feel a little uncomfortable with or intimidated by. And so we'll start with the gender diverse patient. So again, all patients, regardless of gender, should feel welcome, comfortable, and affirmed in the healthcare space. And that can be done by many different people in many different ways. One way is using gender inclusive forms and signage, which I'll show you some examples about in a minute. Hiring diverse staff. So most of us serve a diverse population, and it's really nice to represent that population. Gender neutral language, and so really avoiding gendering people if you're not sure. Consider calling folks in from the waiting room by their last name or the name that they have written on their form, which may be different than their legal name. And introduce yourself. So really every member of the team, when engaging or interfacing with the patient, should really introduce themselves by their name and their pronouns. And so that could look like the front desk staff, office managers, nurses or medical assistants doing vitals or blood work, and again, our pharmacist and PrEP specialist colleagues. And here are some examples of signage. And so really being explicit that this is a welcoming space. And so safe zone training, highly recommend. Having your office policy when it comes to anti-discrimination and inclusiveness posted. Gender neutral bathrooms, and really empowering patients to feel comfortable sharing this information. Here's some examples of gender neutral language. So it's really indoctrinated in us to say ladies and gentlemen, but really there are many other words that we can use. So friends, folks, y'all, depending on where you are in the country. Just being mindful of language is important. Here's an example of a form that I made up. And you can see here it really has many different options when it comes to pronouns and gender. Really explaining the differences between gender identity and sex assigned at birth. And having some like blank spaces for the patient to write it in, because this can be different for different people. So it can really be as simple as this, or if you have an electronic health system that allows for a space to put in this information. This is a dummy patient of ours in our EHR. You can see that there's ample space to put lots of information if you want and if the patient wants. So it's really important also, especially if you're doing this within an electronic health system that the entire institution may be able to see, to check with the patient that it's okay to put this information there, because they may feel comfortable potentially sharing this information with you, but maybe not the whole institution. And sexual orientation and gender identity, or SOGI data, is really important. Some of you may know that back in 2011, the Institute of Medicine called for research investment in this. And the Department of Health and Human Services actually mandated the collection of this data as part of meaningful use. And really putting that aside, these data are critical in helping us understand our population and the disparities that may exist there. It also can hold us accountable to those disparities. So really surveying and making sure that we are delivering and evaluating the delivery of high quality patient-centered care. But we'd be fooling ourselves if this was simple and straightforward, right? And so there's barriers on the patient side, fearing discrimination or stigmatization, worrying that this may negatively affect the quality of their care. And also on the provider side, which we'll focus on a bit. They may feel discomfort or awkward obtaining this information. Again, I hope a little bit less so by the end of this talk. If we go back to the patient's perspective, it's really important to acknowledge that this could be scary for them and potentially dangerous. And so recognizing that trust and acknowledging it can really be meaningful to the patient. We'll talk a bit more about language, but really when a patient shares preferred language with you, especially when we're talking about the sexual history or parts of the exam that involve gendered parts, it's really important to ask what the most comfortable language is and write it down and use it. And so an example could be for a transmasculine person, instead of saying breast, which may be uncomfortable for them, using chest or front or down below instead of penis or vagina. And as always, regardless of gender, it's really important to keep the patient in the loop. And so this is a quote by one of the patients really saying that we know that you have to ask us like odd, weird questions. We just want to know why. And it's important because we need to know our patient, and that way we can provide the best possible care, because we know that certain sects of population will be at higher risk for things. And so the 2015 US Transgender Survey surveyed anonymously online over 27,000 adults who identified as transgender, and 39% of them experienced serious psychological distress. And that's in comparison to only 5% of the general population. 40% attempted suicide in their lifetime, with the vast majority of those being during adolescence and young adulthood. That's nearly 9 times the rate of the general population. And 7% of respondents attempted suicide just in that past year. Yet 31% of respondents reported that none of their healthcare providers knew they were transgender. So this is challenging. And so where can we screen or ask questions about gender identity? I tend to group it with the sexual history, but really you can put it anywhere. And who should we ask about gender identity? Well, I would argue everyone, because you may be the first person asking. You may be the first person that this patient feels safe talking to about it. And it really does go along with other questions that are part of the sexual history. So sexual orientation, assigned sex of partners, and the types of sexual practices. But how do we ask this information? And so it can feel a little clunky or jumbly. And so really finding something that works for you and practicing it. And these are just some examples. And again, at a developmentally and cognitively appropriate level. So when asking about gender identity, you may ask, you were born, say, a male. Do you identify or see yourself as a male? If you're working with youth or those who are more cognitively young, you may want to say, do you feel like a girl, a boy, both, or neither? Sexual orientation. Do you find yourself attracted to males, females, both, neither? Doesn't matter. And if someone's a bit younger, you may want to ask who they have a crush on. And again, more open-ended questions. Can you tell me about them? What do they look like? Things like that. And sexual practices can get a little jumbly when gender is diverse. And so you may want to just be specific about the body parts that are in play here. So what body parts are you in contact with when having sex? Let's talk about Alex. So Alex is a 27-year-old trans male. So that means he was assigned female at birth. He identifies as male, and he shares with you that he uses the pronouns he and him, who presents for a new patient visit. He is called by his birth name, asks to leave a urine sample in the quote ladies room, and senses confusion and discomfort from staff when asking about his last menstrual period. Which of the following is the most affirming example of asking about Alex's sexual history? A, you shared that you are currently sexually active. When having sex with your partners, what parts of the body are you in contact with? B, so who do you have sex with then? C, you shared that you identify as trans male. Do you find yourself attracted to assigned males, females, both, or neither? And D, choice A and C. Okay, and so 12% said choice A, and 88% said choice A and C. So let's go through them. A and C really focus on sexual contact and praxis, as well as sexual orientation. And it's being mindful of gendered body parts and gendered language. And so 0% of you selected choice B, which is good. But really choice A or C and C are most appropriate. So key takeaways here. Gender diverse patients, like all patients, should feel welcomed, affirmed when entering the clinical space. Use forms and signage that convey this message. Be mindful of language. The sexual history can be uncomfortable for everyone, regardless of gender. And so be particularly sensitive to those who are LGBTQIA+. The more you practice asking the sexual history questions, I promise, the less uncomfortable you will feel. And your patient potentially may feel too. So we'll talk about another patient population, biased my favorite population, the adolescent patient. So as we've discussed before, setting the stage is really critical. And it needs to be a little tweaked for the adolescent patient. So oftentimes, and some of you may have experienced this, when you enter the room, there's the patient, the adolescent, and their adult companion. Could be a parent, could be a guardian, could be someone else. And so really acknowledging that you are recognizing the patient, the adolescent, as the patient and not the parent is really important. And so introducing yourself to the adolescent first, and then asking them to introduce the adults in the room. Like so often you do, setting the agenda, right? And so part of that agenda setting needs to include asking the adults if they have any specific concerns that they want to be sure you address. Addressing confidentiality, we'll talk more about this. And then after all that, asking the adult to step out of the room. Conditional confidentiality. And so really aiming to only break confidentiality with the adolescent if they are at risk or someone else is at risk in terms of safety. So usually what I say, my little spiel is, okay, I ask about the concerns and I say, well, we're going to spend this amount of time together. And then I'm going to ask you to step out of the room so I can ask some more personal questions of your child. This is not about keeping secrets. This is about ensuring a private space to really talk about some stuff that may be tricky to talk about in front of a parent. If I have any safety concerns, your child and I will share them either together or just me or just them. But I can assure you that we will talk about any safety concerns that come up. And really, this is important because I want to be the knowledgeable adult that is providing information to this child or teenager rather than their friends, the internet, some other source that might be less evidence-based. And really, I have not had many parents object to that, and it's almost a little bit of a red flag if they do. We'll chat a little more about that. Accentuating the positives, so really taking a strength-based approach. Really important with adolescents is using open-ended questions. So tell me more about your answer to X, Y, and Z. And clarifying, what did you mean when you said, I don't know? Very common response in adolescence. And so kind of taking what you hear and then reflecting back to make sure we're all on the same page is a good idea. And that's really with a patient of any age, but my experience has been particularly helpful with adolescents. And really using the tenets of motivational interviewing, and that's a talk in itself. And if you're unfamiliar with that, I really highly recommend looking into it. It really entails having the teen be an active part of developing a plan. Adolescent autonomy can vary between states. And so the ACLU for your state can be a really good resource for minors' rights and confidentiality rights. And so in the state of New York, for instance, minors have the right to consent to sexual and reproductive health, mental health concerns, substance use treatment. And in 2018, minors have the right to consent to HIV testing, HIV treatment, and preventative strategies like PrEP and PEP without parental consent. This is a graphic from the CDC, and really states have jurisdiction over whether minors can consent for STI and HIV related services. And you can see here the gray states mean that there's no explicit statutes that enable minors to access preventative HIV services. I think this is a little bit outdated because I can see that New York is gray here, but this may be and likely is part of the reason from the beginning of this presentation we saw such a geographic distribution of STI rates, unintended teenage pregnancy rates. So it really, policy is really, really a big factor here. I mentioned a strength-based approach before, and really what that means is a set of ideas, assumptions, and techniques based on empowerment. So really having the teen be an active participant here and recognizing that all youths have strengths, and oftentimes those strengths are not tapped into. And they often come to the healthcare space expecting to be lectured or told what they're doing wrong or told what to do. And really avoiding that can be incredibly refreshing and promote engagement, but really make for rapport building and trust building and have a really productive visit. And by accentuating those strengths, you're fostering motivation for growth and development. Part of the reason I went into adolescent medicine is because it's such an amazing time of development that they're really at this fork in the road. And it's like the crux of opportunity for preventative medicine. And we know that strengths are internal and environmental. And so there are some things that we can't control, but there are some things that we can control. And really, this is another opportunity to pull in your team members to see if there's any services that can help build resiliency in the youth in front of you. So let's talk about Angela. She's a 16-year-old female who comes to the office wanting to discuss contraception. Of note, she lives in New York, where minors can consent to contraception without a parent. So again, you've seen this slide before. Really important to be specific and normalize. You may see some faces that are like, huh, what? And again, reminding the patient that all of this is confidential unless there's an immediate safety concern. So you want to know what type of sex this person is having or not having. And so if you are seeing a patient before they have initiated sexual activity, that's a really nice time to talk about consent. So decision-making involved in deciding to become sexually active, and also preventative strategies, primary prevention, that's the best, right? And so really talking about contraception and parenthood intention and, you know, is this person someone who's like really at risk for some STIs or pregnancy, and really getting in there before they make the decision to start can be really, really empowering for the youth. Really important to avoid those coined phrases like, are you having safe sex? Or are you sexually active? Or are you having protected sex? That can mean a lot of different things to a lot of different people. And so where those open-ended questions come in so helpfully is right here. So what does safe sex mean to you? That's a nice open-ended question that may refer to barrier protection, but also may be risky partner situations that you can talk more about. Screening for survival sex, like we mentioned before, abuse, including sexual abuse, you can touch upon here. And sexual activity is developmentally appropriate for adolescents. And so we have ample literature out there that shows abstinence-only education is not effective. And so really your job is to empower this youth to make the decision for themselves and make the best, safest one that they can make. And again, parenthood intention takes gender out of it. Angela's 5 Ps. So she has sex with assigned males. She's had 2 partners in the last year, 1 in the last 3 months. She has vaginal sex and gives and receives oral sex. She denies any anonymous partners or sex for drugs, money, or shelter. She uses condoms about 50% of the time. And when you ask her, why not 100%? Why not 0%? She states that sex is not always planned, but sometimes it is. And so she doesn't always have a condom accessible. In the past, about 6 months ago, she's had chlamydia and she was treated. She's not sure if her partner was treated. And when asking about parenthood intention, she does not want to get pregnant within the next year. And based on what her friends have said and some research maybe that she's done, she's most interested in the IUD because she acknowledges that it's really hard for her to remember to take medications daily. What did Angela do well? So she used condoms 50% of the time. She came in to discuss birth control options. She got tested and treated for past STIs, all of the above, or nothing. She didn't really do anything good. Well, great. So 93% of you selected all of the above. So using condoms 50% of the time, that is great. Do we want 100% of the time? Yes. Is it more than 0% of the time? Yes. So we can use this as an opportunity to sort of problem solve with her, right? So she said that sometimes sex is unpredictable. So maybe that means you write a prescription for condoms or give her some before she leaves today and she keeps them in her purse. She came in to discuss birth control options. Accessing healthcare can be really hard for adolescents, and really taking that initiative can be hard too. And so she did a really good job there. She is in a risk group for STIs, right? And so yes, she got one of the most common STIs, but she was tested and treated for it in the past. So I would argue that she did everything well. I do want to go on another small tangent. It's related, but there are so many myths and misperceptions out there regarding contraception, and particularly long-acting reversible contraception, that I just want to take some time to talk about it. Because really, when providers and patients hold these misperceptions about risk associated with contraception, teens' choices are unnecessarily limited. Let's talk about IUDs in particular. And so you can see these graphics here are of old IUDs that are terrifying looking, right? And so way back when these were on the market, they have been since pulled from the market, and the IUDs now available or intrauterine devices are T-shaped devices. And so the current IUDs can be used in patients who have never had a baby before, or nulliparous women. Previously, that was not the case. They can be used in people who have had an ectopic pregnancy. They can be used in people who have had an STI and or even PID, or pelvic inflammatory disease, in the past. And the American Academy of Pediatrics, the Society of Adolescent Health and Medicine, the American Congress of Obstetrics and Gynecology all recommend that LARC, including IUDs, be offered to adolescents. They do not cause PID, nor must they be removed to treat PID. And so there is a slight risk at the time of insertion, but it is not something that needs to hold you back. You can test for STIs at the time of insertion, and having one at the time of insertion can increase your risk, but again, it is not a contraindication. And the devices themselves do not cause infertility. There's lots of studies that show this, but untreated chlamydia can. So here's a bonus question, because this is not a contraception talk, but given Angela's STI risk and history, can you place an IUD today? Yes or no? Okay, so 79% of people said yes, and 21% of people said no. And so the answer is A. And so yes, you can. And so this is just like an important general point. Really, when it comes to contraception, everything needs to be seen through the lens of the alternative being pregnancy, right? And so this young person made it to your clinic, is interested in contraception, is identifying that that's a need for her. She is in a risky age group, sure, for both STIs and pregnancy prevention, but really unless you are seeing evidence of active cervicitis or pelvic inflammatory disease at the time of insertion, cervical motion tenderness, something like that, there's no contraindication to placing the IUD today. And again, you'll do a swab for STIs at the time, and you'll treat them if they pop up, and you'll give, symptoms to look out for, abdominal or pelvic pain, which happens with IUDs, but really having, close eyes on the patient if they have a positive STI test at the time of insertion, but it is not a reason to not place it. So key takeaways for section 3. Adolescence is a unique stage of development. Your approach to sexual history needs to take this into account. Practice asking the components of the sexual history in a developmentally and cognitively appropriate way. Please, 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 please know your state's reproductive health laws for minors. I'd like to take a moment to go through some of these resources. And so I mentioned at the beginning of this presentation, the CDC's guide. It's a PDF for sexual health, like sexual history gathering. And when I reviewed it, it really did seem a little outdated to me. And so I really liked the National Coalition for Sexual Health, their provider guide, also a PDF. Just seems to take language into account and just a more modern approach, I would say. Here are several resources for sexual and reproductive health rights for minors. And so the ACLU, like I mentioned, Guttmacher is a really nice one, specifically talks about abortion rights in the various states. And as always, the CDC. This is a really nice reference for both providers, but also patients. And so more so patients, I would say. It's called bedsider.org, and it's evidence-based, but really patient-friendly. And so this is a screenshot of their homepage. And really, if you click on each of these, I'm a visual learner, and I think a lot of patients are. And so if you click on each one of these little pictures, and it's a nice opportunity also to talk about Angela, if she walked into your office, you could be like, yep, we're not going to offer tying your tubes, right? We're going to talk about the most efficient methods, which is LARC, IUD, and the progesterone implant. We can break it down into progesterone containing, so these guys over here. We can talk about estrogen containing, so the pill, the patch, and the ring. Condoms always for STI prevention. Abstinence is your choice, right? And some of these we don't really offer, like spermicide and things like that. So once you click on the different methods, it takes you to an information page, the pros, the cons, the costs, how to apply or use them if applicable, some videos from real patients. It's a really nice reference. This is more for providers, so it's really handy. Some of you may remember like a laminated grid with lots of different colors, green and red and pink, with all the different contraception methods and many, many medical conditions or medications. And so that's the medical eligibility criteria for contraceptive use. And thankfully, the CDC made an app, which is really, really nice, and it divides it by condition and also method. And so you can see here are the different methods. It also comes with the selected practice recommendations. And so some of you may encounter like, ooh, this person's last unprotected sex was like 2 days ago. Their last period was, I don't even know. Could this person be pregnant? And so this first selection up here tells you how to reasonably be certain that a woman is not pregnant. And again, all contraceptive counseling and potential provision needs to be taken with the alternative of pregnancy. I hope most of you know about this one, the CDC's STD treatment guidelines, really, really handy of how to treat all the different STIs, diagnostic considerations, alternative regimens, and some data behind it. So that's a really nice one too. And I think at this point, we'll open it up for questions. All right, one question that came in was, what strategies can you recommend for sharing information obtained from a sexual health assessment with other members of the team so patients don't feel you violated their trust or privacy? That's a great question. And I think it's important as part of the setting of the stage to really acknowledge the team system that you work in. And so saying like, okay, we just did our comprehensive contraception counseling and you have selected the combined oral contraceptive pill that is, it seems like it's going to best meet your needs. We've gone through the medical eligibility criteria and you have no contraindications. I have briefly counseled you on venous thromboembolism risk, but my partner in pharmacy is going to come in next to really talk to you a little bit about the nitty-gritty of how to take this pill and other things to look out for. Would that be okay? Really, at the end of the day, you can never go wrong by asking permission. So like 2 key concepts, making sure the patient understands why you're doing or asking what you are doing or asking, and being sure that you have their permission to do that. What are common missteps in taking a sexual health assessment that you've seen other providers or you've seen providers with the best intentions make? I think it's really that human factor. It's the intrinsic judgment and assumptions. It's implicit bias, right? And so we are all human. And so if we are humble humans, we can recognize that we're making a mistake. Granted, there are a lot of factors working against us as members of the healthcare team, right? We've got time constraints, we've got documentation constraints, we've got technical difficulties, right? So there's a lot that can go wrong, but really doing your best to follow some of these recommendations and guidances that I shared with you to really, again, build that trust, be specific, get the information that you need, no more, no less. Make sure the patient understands why you're asking these questions and that it's not because you're curious, especially for gender diverse patients. There's also a pretty decent body of literature that talks about a gender diverse patient going to the emergency room because of arm pain. And so a, binary patient, male or female, will, have an exam, maybe an x-ray, but the gender diverse patient suddenly is being asked questions about their transition, about their medications that are unrelated. They're a really interesting case. So all of the trainees and learners come in. And so it's actually called something. It's called trans broken arm syndrome. And it's just really this we somehow were ruling out a broken arm and potentially a pelvic exam happened. And so really, really being mindful. It's always good to have intellectual curiosity, but not at the expense of the patient. Good questions. I can share a few others that have kind of come up along the way. Let's see, I wrote them down. Let's see. So what do you do if a parent doesn't want to leave the room? And so that's when your spidey sense really needs to be activated, right? So is it because and I shouldn't say parent, I should say adult, right? So is it because they have a concern that they have not shared with you yet? Is it because they're worried that you're going to talk about something that they should know about or they think they should know about? And so at that point, I would say, like, you know, tell me a little bit more about what your concerns are about leaving the room, like just getting the information. Sometimes that's a moment where, like, is this youth being trafficked, right? Is there like an adult here that is like really inappropriately refusing to give private space? And really being mindful of that. And it has happened. And so having signage in the bathrooms about domestic violence or intimate partner violence and sex trafficking and things like that, really not leaving that person in the room alone with the adult. So maybe it means like, okay, we need to get a urine sample. I'll walk you to the bathroom, and pulling in your other team members, case managers, nurses, things like that. And so really being mindful of these cues, but also more commonly, it's just an anxious parent or adult that is like really not sure what's going on. And a whole nother talk is like the transition of medical care from pediatrics to adulthood. It's poorly done often. And so it's really hard for that parent or guardian to really like take a step back and let go. And so oftentimes it's just that. And with conversation, you can kind of overcome that. What else do I have here? Let's see. How to approach a team who is ambivalent about pregnancy or STI prevention. And so this is not an uncommon situation. So like, yeah, I don't really want to get pregnant, but like, whatever, if I do, like, it is what it is, right? What am I going to do about it? There's lots that can be done, right? And so really kind of going through, again, using that strength-based approach, using motivational interviewing to really better understand this person as a whole. So what is this young person's goals? Like, they're in high school. Do they want to graduate high school? Cool. Do they want to become something, go to college or tech school? Great. How will having a baby potentially be a barrier to them accomplishing their goals? And so sometimes it really just takes like a conversation about it, which is very uncommon, I think, for a lot of teens when they enter the healthcare space, to really be asked those questions. And so again, identifying sort of future orientation and motivators for that patient in their life. And teens are very present oriented. It's really hard for them to think about the future. But if you think about just maybe a few years ahead, they can do that. Not like when they're old and like maybe they'll get a blood clot, like they can't really think that far ahead. And so really trying to identify what their current and near future present goals are, and challenging them about how will this STI or this pregnancy get in the way of that? And are there ways that we could kind of move on and not have that be a potential issue? And if so, which of those ways makes the most sense for that patient? Okay. So sexual history gathering is an essential part of providing quality, comprehensive medical care. Remember the 5 Ps, use the mnemonic of your choice, normalize, avoid judgment, be inclusive and affirming. There are many preventative strategies, contraception, PEP, PrEP, but you cannot offer them if you don't ask these questions. And use a team-based approach. Team is your friend. Okay. Well, I just want to take a moment and really thank all of you for coming, thanking the American Academy of CME and ACT HIV for inviting me. And I hope you have a great rest of your day and stay safe and healthy. Thank you.